Good afternoon, everybody, and welcome to this afternoon's virtual lunch meeting. My name's Sam Chakosky, and I'm the sales manager for the JCN. I'd like to just start by saying a big thank you to you all for joining us today. We really do appreciate you giving up your afternoons to be with us. So we hope you enjoy the session and make the most of it. Remember to get involved throughout in the comments section, and you'll have a great session today. So today's session is titled 3 Real-World Improvements with the Next Generation of Gelling Fibre. And we have 2 speakers for you today. We have Meave Alexander and Sarah Foster, who are both clinical support managers at Mölnlycke. Hi both.
Hi.
Hi.
So just before we get started, I'm just going to run through a couple of bits of housekeeping really before the sessions begin. Firstly, I'd just like to thank Mölnlycke for supporting this presentation. We really do appreciate your support. For all you viewing this, we'll be posting a link to certificates at the end of the session. So keep an eye out for that. We'll pin that in the comments section as well, so you can't miss it. You'll notice this is a remote session, so do bear with us if there are any technical issues. We'll try and get those sorted as quickly as possible, but one of our team will be in touch with you all, keeping you in the information in the comment section, so don't worry about that either. And finally, just remember to send any questions through. So we'll have a live Q&A at the end, and I'll be asking the questions to Meave and Sarah in that live Q&A. So ask as many questions as you like, and we'll get through as many as possible. So I'll now pass you over to Meave, and I'll see you at the end for the Q&A. Thank you.
Hello, thank you, Sam, for the introduction. We're really happy to be here today. And hello, everyone, and thank you for joining us. We hope you enjoy today's virtual lunch meeting and you find it both interesting and informative. Sarah and myself are excited to share examples of real-world patient case studies that we thought might be familiar to many of you watching today from your own patient caseload. We understand, as clinicians ourselves, wound care management can be challenging, and getting the conditions right for healing is essential. And we hope that with today's session and the launch of our new gelling fibre range, Exufiber, we will be able to offer a fresh take on those challenges and provide improved solutions for effective wound care management. I'm now going to pass you over to my colleague Sarah, who's going to introduce today's learning outcomes.
Thanks, Meave. Hi everyone, and welcome to today's session. So here we've got some learning outcomes. Firstly, we'll take a look at some of the key facts that were highlighted by Julian Guest's recent study. This newly published paper assessed the extensive change in the burden of wounds to the NHS over a 5-year period. That period was from 2012-13 to 2017-18, and it addresses the annual prevalence, health outcomes, healthcare resource use, and also cost to the NHS. Next, we'll reflect on our patients and the impact of living with a chronic wound and what impact that has on their life. And then we'll explore solutions to treat those unhealed wounds and improve wound care management. Moving on then to our range of gelling fibres, we will discuss the challenges of managing highly exuding wounds and cavity wounds. And this will include some real-world case studies which illustrate the key benefits that Exufiber can offer. We will then end with an overview of our 14-day challenge and also look at how Mölnlycke's clinical support managers can offer 360-degree support.
Thank you, Sarah. Well, in order to help us understand the challenges of wound care today on the NHS, we took a look at the recent study by Julian Guest. This study highlighted that an estimated 7% of the adult population in the UK has a wound today, resulting in an estimated cost of £8.3 billion per year, which is an increase of 48% since the previous study back in 2012 and 13. To us, this demonstrated the growing challenges that wounds present the NHS today. Prior to joining the event, we asked you to complete a short survey, and thank you so much for taking the time to do this, as your feedback really helped to shape today's session. One of the questions we asked you was what you thought the percentage was of that 8.3 billion cost of wound management is related to dressings. You said 14%. Well, it might surprise you to hear that it's actually 6% of all the costs come from wound care products. However, the previous study, it was 14%. So this reduction raises the question, well, what is driving the increased costs? Well, this is down to a number of factors. However, the study did highlight that 5.6 billion of the cost is due to non-healed wounds, with healthcare practitioners' visits accounting for 71% of all wound care costs. So if we consider those unhealed wounds, what do you think they are? Well, the study showed an estimated 1 million adults in the UK today has a lower limb ulcer, and Sarah is going to explore this in more detail shortly. So you might be interested to also know that diabetes is now the #1 comorbidity in relation to wounds. It'd be really interesting to hear what you think of these figures and what was most shocking to you. So we do encourage you to make comments in the chat function throughout today's session. But I think you might agree that overall the findings highlighted a need for wound prevention, holistic assessment, and wound management. And Mölnlycke aims to be part of the solution to help reduce nursing time and cost, while most importantly, achieving the best outcome for the patient. And we're going to talk about how we can support you with all of these challenges in today's session. So back over to you, Sarah.
Thanks, Maeve. So one of the questions in the survey that we asked you to complete before the session was, what type of wounds do you currently use a gelling fibre on? So you said that the highest percentage was on lower limb ulcers, and then pressure ulcers, and also malignant wounds. And I feel that these answers really do reflect the increases in prevalence, which are detailed on the new Julian Guest paper. The figures there showed a 101% increase in venous leg ulcers over a 5-year period, with 85% of those patients being managed on district nurse caseloads. And other big increases in prevalence are seen, with a 244% increase in arterial leg ulcers and a huge 325% increase on mixed leg ulcers. So from this, we can clearly see that this really is an ever-growing problem. So the slide that you are currently viewing shows images there of current chronic wounds with different etiology. And I'm sure the images of these types will be familiar to many of you with patients that you care for on your current caseloads. But I just wanted to take a couple of minutes just to think about what it must be really like for somebody to actually live with that type of chronic wound. So as clinicians, you will all know that wounds like these can take months to heal, or they may never even heal completely. And the impact of having a chronic wound can be devastating to somebody's quality of life. It's not just the fact that they've got the wound, but the pain from that as well. The surrounding skin, which may have become edematous, sore, or excoriated. And then there's also the worry of whether they might get an infection in the wound, or if the exudate is going to leak out onto their clothes or bedding. And then there's the issue of malodor too. And that particular issue actually takes me back to my experience when working as a district nurse, thinking about a lady that I looked after, and she'd got a severe fungating tumour. She had a wonderful large family, but very, very sadly, she'd stopped them from coming to see her. And that was because she was so embarrassed about the smell of the wound, because that then led to uncomfortable and awkward questions from other family members or young grandchildren. So we can see that situations like these can have a huge implication on our patients' well-being, and that can then sadly lead to social isolation. But by selecting the appropriate dressings for the right etiology wounds at the right time, we can ensure that our patients are then receiving the best quality of care, and good healing outcomes can then be aided by the appropriate use of dressings. So back over to Maeve to talk about the clinical challenges in chronic wound management.
Thank you, Sarah. Well, if you think about the management of chronic wounds, we know that this can present us with 3 complex clinical challenges, which we're going to explore in more detail today. This is where your survey results really came into play. We asked you to consider the performance of the gelling fibre that you are currently using in practice and give us your top 4 areas you'd like to see improvements. You said number 1, absorbency. Number 2 was exudate transfer to the secondary dressing. Number 3 was wear time, and number 4 was reduction in bioburden. The key challenges that we're going to discuss and which are linked with these results are the issues caused by residue or debris, which being left behind within the wound bed upon removal of the dressing, which we know can delay the healing process. High exudate levels and how to support not only with absorbency, but the efficient exudate transfer from the wound bed to the secondary dressing, whilst promoting undisturbed wound healing with a longer wear time. And biofilm reformation, which we know can disrupt the natural progression towards healing. So we know that these clinical challenges can severely affect our patients' quality of life and have detrimental effects on both our clinical resources and budgets, which includes your time, the volume of products that are used, and the waste that is associated. So you may be asking, how can we help in light of these challenges? I'll now pass you back to Sarah to explore this further.
Thanks, Maeve. So in light of those three very complex clinical challenges, there is consistent innovation in healthcare where new dressings and therapies are being developed, and these can support both the patient and clinician, but also taking into account the increasing pressure to ensure that such developments are also cost effective. So thinking again back to the survey that we asked you to complete, one of the questions there was what have been the biggest challenges affecting wound care over the past year? In view of the year-long pandemic that we're all still unfortunately experiencing, you said that the biggest challenge had been accessing appropriate dressings for your patients. The next biggest challenge was reduced nursing time. So that's meant by the time that's actually spent hands-on nursing your patients. Access to education and training was third in line, and challenges around dressing leakage and maceration was also very high on the list. And I do feel that that particular challenge could be directly linked to the first biggest challenge, which you said was that difficulty in accessing appropriate dressings. And it could also be linked to problems with your staff being able to access training and education over that difficult period. So with all of these things in mind, we're delighted today to be able to show you Mölnlycke's new range of gel and fibre dressings, Exufiber and Exufiber Ag+. The dressing is constructed in a completely different way. So it has Hydrolock technology, and that's what makes it the next generation of gelling fibres. So we're aiming to improve patient outcomes by creating an optimum healing environment, not only in the wound bed, but also deep within the cavity wound too. So back over to Maeve to take a look at how the technology works in a little bit more detail.
So I can hear you all asking, what is it that makes Exufiber so different? Well, firstly, I would like to talk about Hydrolock technology, because Exufiber is the only dressing that is constructed in this way. So if you take a look at the top image that you can see on your screen now, this is what Hydrolock technology dressing, so Exufiber, would look like when viewed under a microscope. And you can see how different this looks in comparison to the image below it, which is your traditional hydrofiber dressing. Well, Exufiber is a non-woven polyvinyl alcohol dressing, and it's the way the fibers are thicker and interwoven that helps lock away exudate, therefore trapping the bacteria into the dressing away from the wound bed, reducing the risk of cross-contamination. But most importantly for your patients, this helps prevent leakage and reduces the risk of maceration. The dressing, as you know, will transform into a gel upon contact with exudate, which has the benefit of making it softly conform to the wound bed and also supporting with that moist wound healing environment and autolytic debridement. One of the great things about Exufiber, it has a very strong tensile strength. So even when it becomes completely saturated, the dressing will stay intact for an easy one-piece removal. So you can be confident that all the dressing is removed when you're extracting from a cavity wound. I'll now pass you back over to Sarah. Thank you.
Thanks, Maeve. So the next important area to consider is how we can really optimise the space for healing. So by having a dressing which not only absorbs, but also transfers exudate up into a secondary dressing, we can be sure that there's no pooling of exudate in the bottom of the cavity. In our clinical practice, we know that chronic wounds with tissue loss will heal by secondary intention, which means that the healing starts from the bottom upwards. So this transfer of exudate property is a really important aspect in a dressing. We know that for wounds to heal, they also require a clean wound bed with no occlusion from slough. So a dressing which facilitates autolytic debridement, which will promote the development of healthy granulation tissue, which is then ready for epithelialization, will result in efficient healing. This clean wound bed is also supported by a full one-piece removal of the dressing without leaving any residue behind. And we also want a dressing which will continually deliver silver ions to kill bacteria. So following debridement of the wound bed, it's then really important to maintain the prevention of the biofilm reforming. Okay. This means that the bacteria then cannot thrive without its protective biofilm shell. Therefore, the bioburden will reduce. So let's take a look at these three areas in a little bit more detail.
As clinicians, we already understand the importance of absorption and retention being key performance factors we look for in a gelling fibre dressing. The other factor to consider is the way the exudate is transferred into the secondary dressing. When we have a dressing that can deliver in all these three areas, absorption, retention, and exudate transfer, then we can be sure we're using both the primary and secondary dressing to their fullest capacity. So what does that mean in the real world? This means less dressing changes, which will promote that undisturbed wound healing, giving clinicians the confidence to leave the dressings in place. To help demonstrate the transfer of exudate, we're now going to hear from Paulo Alves, who is a professor of nursing and tissue viability at the University of Portugal. Thank you.
What you need when you're talking a cavity wound, you need to absorb the large amount of exudation that you have on that wound. But in the end, you need to transfer the exudation from the bottom to the top. And that's where you need to select the perfect dressing. The second dressing has a different behavior because you fulfill exactly as the same as the first one. But the problem is when it starts to absorb, it only absorbs the area that is in contact with the exudation. So it doesn't transfer. What happens? In the end, it absorbs, jellifies, and works like a plug. So working like a plug, it will leave the rest of the exudation in the bottom of the wound. That's not the good environment to the healing rates. What you have here, it's the same cavity wounds with two different dressings. We are going to apply in the both dressings the same amount of fluid, and you can see the behavior. It's almost similar between both. It starts to absorb in this capacity, but in a certain moment when the liquid stops, you can see immediately that on the left side the absorption continues and the transfer of fluid to the superior layers, it's maintained. On the right side, it's not the same behavior. You see there's a lot of collection of fluid on the bottom, and on the left, you see that they have, again, empty spaces without any kind of fluid. So you can see immediately there's a huge difference between both of them. Large space and fulfill of fluid. When you try to implement again the same amount of fluid, you see again the same behavior. Starts to absorb, but on the left side, you see the transfer of humidity to the superior layers. And on the right side, you see that stops only on the part that is in contact with the dressing. On the left side, you see again that you have a larger spaces, and you see there's a continuous absorption of the fluid. And on the right side, there's a large amount of fluid on the top. That's what we cannot see while we are in daily practice. But we imagine that in the bottom, we are not expecting to have a large amount of fluid, as we can see on the right side. So now when you start to take out the dressing, you see how the dressings on the right side are not saturated. So you have a large amount of fluid on the bottom and the dressing is not saturated. And on the left, it's completely absorbed the fluid. And you can see here in the hand, it's amazing the difference with the same amount of exudation. There's a huge difference on the amount of exudation from the left, from the right side. You see on the right side, the plug effect that I talked previously, because it's not able to absorb the amount of exudation that we want on that wound.
So thank you, Meave and Professor Alves. A really interesting test done there. And it would be so great to hear your thoughts too. So please do share these in the chat and also any questions that you'd like us to answer at the end. So the next area to look at is how Exufiber can help support a clean wound bed. And to do that, we're going to look at the first of our real world case studies with a patient who has a chronic diabetic foot ulcer. So the reason that this paper has been chosen is because we recognise that diabetic foot ulcers pose a serious problem for diabetes patients. Diabetes is increasing, and Julian Guest's new paper shows that the prevalence has actually doubled in 5 years, and that 9% of all adults with diabetes have now got an active foot ulcer. These wounds can also unfortunately lead to lower limb amputation, and statistics show that having a diabetic foot ulcer can increase the risk of death by 2.5 times. And in addition, there's also a high risk of infection, and patients can experience varying levels of exudate, and this must be effectively managed to avoid maceration, leakage, and also malodor. So back to the case study. So we've got a 68-year-old male patient who was admitted to hospital. The reason for admission was unknown at the time. There were no other comorbidities noted for this gentleman, and the notes documented that he was obese with a body mass index of 49. Upon inspection, he was found to have a chronic diabetic foot ulcer to the left heel, and you can see that illustrated there on the slide. So in terms of wound history, due to the hospital admission, the initial onset date of the wound is not known, but the records reflected that the wound was more than 6 weeks old, but less than 12 months old. And at the first visit, the wound was exuding heavily with a serous exudate. And also, as we saw on the previous image, the peri-wound area was also very macerated and broken, with erythema there as well around the edges. The wound dimensions were recorded at 42 millimetres long by 60 millimetres wide, and the wound bed presented with 80% slough and 80% fibrin mixed with slough. So a treatment plan was put together, and that included sharp debridement of the wound bed and then application of the Exufiber Ag+ as the primary dressing. So as you can see up there in the photographs, after 7 days of treatment, the wound area had decreased by 59.8% from the baseline and showing a clean wound bed with 100% granulation tissue. By day 21, the wound size had further decreased with 85% granulation tissue and 15% epithelialization tissue present on the wound bed. And at the last visit, which was a total of 30 days treatment, the wound area had decreased by 90.3%. So in terms of clinical outcomes, Exufiber Ag+ dressing was evaluated as good to very good at all visits. And this was in the areas of ease of application, removal in one piece, the ability to absorb and retain exudate, and also to conform with the ability to clean the wound bed. So as you'll all know from your clinical practice, the foot is a really difficult area to manage, not only with the issues of gravity and exudate management, but also finding a dressing that can be worn under footwear or offloading devices, which is also non-bulky, comfortable and conformable. I hope you found that interesting and relative to your clinical practice. Please, again, do add thoughts into the chat function or any questions again that might have come up. And handing back over now to Meave for the next area.
Thank you, Sarah. So recent clinical evidence shows that biofilms are present in almost all chronic non-healing wounds. And as you know, their presence may prevent healing. So we're now going to take a look at an animation of how Exufiber Ag+ works to kill bacteria and prevent reformation of biofilms. Thank you.
This is Exufiber Ag+, a new generation antimicrobial gelling fiber. Exufiber Ag+ combines the Hydrolock technology with fine silver sulfate crystals. When exudate comes into contact with the dressing, the crystals dissolve, releasing silver ions. Thanks to the combination of silver sulfate and Hydrolock technology, this release of silver happens fast, within 30 minutes. The antimicrobial mode of action of silver works 3 ways. First, the bacteria cell membrane rupture when Ag+ binds to the proteins of the cell membrane. The membrane could break and the contents of the cell could leak out, resulting in the death of the bacterial cell. Second, The silver ions might also bind to bacterial enzymes, resulting in the inability of the bacteria cell to perform processes necessary for respiration or to take in or process nutrients. What's more, the silver ions disturb replication. Ag+ might bind to bacterial cell DNA and interfere with cell division and the replication process. The silver ions in the fluid will strive for equilibrium and thus divide homogeneously in the wound fluid. This is how Exufiber Ag+ is effective in targeting and killing a broad range of wound-relevant pathogens fast. In chronic wounds, bacteria often live as biofilm aggregates encapsulated in a matrix. Evidence suggests that serial wound debridement could provide a window of opportunity of less than 24 hours, in which antimicrobial treatments are at their most effective in reducing both planktonic and biofilm microorganisms in wounds. It was found that Exufiber Ag+ had a significantly greater effect on biofilm bacteria. The Davis studies in vivo on pigs shows Exufiber Ag+ is significantly more effective in reducing biofilm bacteria for both Pseudomonas aeruginosa and MRSA. Thanks to the combination of Hydrolock technology and silver, Exufiber Ag+ kills bacteria and removes wound debris that support bacteria growth and biofilm formation.
I hope you all enjoyed watching the animation and find it informative, and please do continue to share your thoughts in the chat function. I'm now going to show you a case study from a patient in Brazil. This is a 54-year-old lady who attended a treatment clinic where she presented with chronic venous insufficiency. She also had bilateral great saphenous vein reflux and large varicose veins with a venous leg ulcer to her left ankle. In her job, she worked as a housekeeper, which meant that she was often standing for 10 hours or more a day. She had a medical history of arterial hypertension, depression and insomnia, along with severe pain syndrome with a visual analog scale where 0 was no pain and 10 being severe pain. This poor lady's pain score was a 9. Her other comorbidities included esophagitis and gastritis due to chronic long-term use of anti-inflammatory drugs as analgesia, and her BMI was 18.3. In May 2019, she was referred to a clinic with a complicated chronic venous leg ulcer. And unfortunately, she had had this ulcer for 17 years without any signs of healing. And the wound was located on the anterior side of her left ankle, and there were clear signs of infection, high levels of exudate, and dry skin around the peri-wound area. The baseline measurements were approximately 28 centimeters squared with a depth of 0.2 centimeters. And I think you would all agree this patient presented with complex needs. And I'm sure some of these experiences you'll be able to connect with from your own patients on your everyday caseload. So now let's take a look at the treatment plan and the results. So following an holistic assessment, a treatment plan was followed. And this included psychological support, control of arterial hypertension, nutritional advice, oral antibiotics, ultrasound treatment of the great saphenous vein and tributary areas. Topical wound management included sharp debridement to the wound bed and removal of slough, followed by compression therapy. Exufiber Ag+ was chosen as the primary dressing, with Mepilex border as a secondary dressing. And after the first appointment, the patient attended follow-up visits, and these are illustrated on your screen at the moment. So the day 2 visit was due to an infection, but as you can see, visits then became less frequent, and you can see on the image that the wounds followed a really healthy healing trajectory from day 7 to day 34. And after only 16 days of treatment, Exufiber Ag+ was no longer required, and they stepped down to using just the Mepilex border comfort alone, as the local infection and exudate levels had been well controlled. So overall, a really good response to topical and systematic treatment was achieved. And the study found that both dressings worked well under compression, And after only 7 days of treatment, the patient's pain score has significantly decreased from a 9 to a 2 and down to no pain on day 16. And after 17 years of living with a chronic venous insufficiency, the holistic approach to treatment and utilising Exufiber Ag+ has resulted in a life-changing event for this lady. So let's hear from a couple of clinicians' experience of using Exufiber with their own patients. So as you can see, Professor Paul Chadwick, who is the National Clinical Director for the Royal College of Podiatry in the UK, found the all-in-one dressing removal to be really key, and he was really impressed with how clean the wound bed was in comparison to similar products he'd used previously.
And Christine Redford is a podiatry clinic from Morley and District Primary Care Network. She uses Exufiber and she's found a reduction in maceration around the peri-wound area of a foot wound, and she says that it's a fantastic product and it does what it says on the tin. So as clinicians, we know the importance of finding the right product for the right patient at the right time. So with everything that we've learnt in today's session, why don't you try Exufiber out for yourself? We really want to give you and your patients the opportunity to experience the benefits that we've talked about today. So have a think about those patients that you currently manage where a gelling fibre is used as part of their treatment plan. And by taking part in the 14-day challenge, can you improve their patient experience and the clinical outcome by using Exufiber instead? The full details will follow about how you can access samples of Exufiber to use for your own 14-day challenge. We also have a team of clinical support managers who can support you through the process of the Exufiber evaluation. So I know that the data on this slide will be really small on the presentation, but it's really just to show you the way that the clinical team are strategically placed across the country so that we can provide that local support. This slide is available in the slide deck, so when you download that for your reference, so you can then check out who your local contact is, the phone number will be there, the email address, so please do get in touch. And also if you complete the form at the end, you'll be contacted by your local CSM, and they can then arrange to provide samples and also plan any support which might be needed as you carry out your evaluations. So what is our 360-degree support? Well, as clinical support managers, we're all registered clinicians who have previously worked within the NHS and also private sectors, and therefore we understand the clinical challenges that you face. So as well as supporting you with tailored evaluations such as this 14-day challenge, we can also provide training and education to update knowledge and skills which can be delivered to healthcare professionals either virtually or face-to-face when restrictions are finally lifted. We can also support you and your teams with a training needs analysis, which will help to identify gaps in the knowledge within your team. And then from this, we will put together a bespoke rolling training programme specifically to suit your training needs, and where pathways and protocols are needed, we can then assist in the development of those as well. So again, please do share your thoughts on our educational offering by using the live chat function here. And also if you've any questions, please do pop those into the chat.
Thank you, Sarah. Well, we're really looking forward to supporting you with the 14-day Exufiber challenge. And if you'd like to find out more about Mölnlycke's educational support, please do go onto our website where you'll find our Mölnlycke Advantage training and education platform. Here you'll find webinars, podcasts, e-learning modules and training for specific therapy areas such as pressure ulcers, skin tears, diabetic foot ulcers, surgical wounds and many more. We also run regular webinars and Facebook Live events. And you may be excited to hear that we have a new wound support app and a case finder app, which we are more than happy to discuss with you. So please do get in touch. We would like to thank you for joining our virtual lunch meeting today. And we hope that you found it interesting and it provided some improved solutions for the wound care challenges that you face. And we really do appreciate you taking the time out of your busy day to attend. I'd like to also thank JCN and Sam for hosting the session today. And I'm now going to pass you back on to Sam. Thank you very much.
Brilliant. Thank you very much, both. Really, really interesting session. It's some great information, and we've had lots and lots of comments and lots of questions come through. So we'll now move over to our real-time Q&A session. For all you viewers, make sure you keep sending in any questions you have for Maeve or Sarah. We'll get through as many as possible during the live Q&A, and if we don't get through to your question, then we'll answer that in the next couple of days as well. Okay, so moving on to our first question. So this one's from Judy, and Judy asks, how long can the dressing stay intact?
The dressing, Exufiber can be worn for up to 7 days, but we do recommend regular wound assessments. And also bear in mind that Exufiber can also be worn for 14 days on donor sites. So that is an exception to the rule. Is there anything else?
I think just also to add to that, just to be aware of the secondary dressing that you choose as well, because, you know, with the Exufiber being able to transfer into the secondary dressing, you know, by choosing a good absorbent dressing for your secondary dressing, then you can really maximise that wear time.
Perfect, thank you. So question 2 is from Rahima, and Rahima asks, is the dressing only to be applied on deep cavity wounds, or can it also be applied on shallow wound beds?
Do you want me to?
So either of you? Sarah, do you want to take this one?
Yeah, sure, yeah. So no, you would use this also on shallow wounds. So I think if you just think about it, as wherever you would currently use that gelling fibre, you could also use Exufiber as that product as well. So it would be, yeah, primary dressing that you could also use within a shallow exuding wound.
Absolutely.
Thank you
very much.
I can just add that Exufiber can be used on a number of different wounds, and we might not have actually covered that in the session. So this would be your leg ulcers, or arterial, venous, mixed ulcers, diabetic foot ulcers, pressure ulcers, malignant wounds, surgical wounds, donor sites, and partial thickness burns. And I don't think I've missed any from that.
Perfect. Thank you very much. This question's for you, Sarah. Could you use Exufiber instead of alginate?
That's a really good question. Thank you. So thinking back, alginates were first introduced for exuding wounds back in the 1980s, and gelling fibres were developed as the next step up from that in the 1990s. And many clinical studies do show that gelling fibres outperform alginates in key areas because the mode of action is different, so the way that they work is different. And if any of you have used both of these products, then you will have experienced differences in absorption and also maybe the way the dressings hold together. But with Exufiber being the next generation of gelling fibres, and as we've seen in the presentation today, the Hydrolock technology can outperform a CMC dressing or a traditional gelling fibre product. So again, by thinking about the way that works with the mode of action, where Exufiber will absorb and lock in exudate, so even under compression, and also the ability for it to be able to transfer exudate up into the secondary dressing with that one-piece removal as well. So all of those things, yeah, make Exufiber perfect to be used instead of an alginate.
Brilliant, thank you. So question 4, Maeve, I'll pass this one to you. This one's from Jenny. Jenny asks, what type of dressing would you suggest as a suitable secondary dressing for this product, particularly on foot ulcers?
Thanks, Jenny. That is actually a really good question. So we do recommend a bordered foam dressing. And as Sarah mentioned before, you want something that is going to have a certain degree of absorbency. So the exudate can transfer from the Exufiber dressing to that secondary dressing, and also reduce the risk of skin maceration. And I also recommend choosing a dressing, you know, of appropriate size as well. So that's really key. And you can also use, if it was a very deep ulcer, bear in mind that you could use the ribbon format instead of the flat dressing format for the Exufiber as well. So yeah, because you don't want the dressing to be too bulky for a foot ulcer. because obviously you want your patient to be able to put shoes on and go about their daily lives.
No, absolutely. Anything to add there, Sarah?
Yeah, I think that's a really important point there, Maeve, at the end. You do want that so that they can carry on, with their usual daily activities. So the dressing also needs to be really conformable, because the foot, is a difficult area to manage. So again, something that's going to conform to the area and stay on really well is going to be good too.
Brilliant. So I think we've got time for a couple more questions. So we'll move on to question 5. This one, Sarah, if you don't mind answering this one, from Leslie. Can you cut this dressing to get into areas of tracking?
Yes, so you can cut through Exufiber. There's no problem there with, the way that the dressing is formed. So you can cut that, if you wanted to cut that into a ribbon. So even though we do have the ribbon available of the dressing, if you wanted to make that into a different kind of shape, then yeah, absolutely, you can cut that into whichever shape that you need it to be. Perfect.
So on to our final question. This one for Maeve. Is Exufiber available in different sizes, e.g. ribbons, and what is the largest size? I know you've touched on this a couple of times, but if you can go into a bit more detail, that'd be great.
Not a problem. Well, what's great about Exufiber, it comes in a very broad range of sizes. So if you're just talking about the flat version of it, it starts in a 5x5 and goes right up to 10x30. And that 10-30 is a great size for those, odeminous leg ulcer wounds. And also we do have as you mentioned before, we do have the Exufiber in a ribbon version. And this has a length of 45 centimeters, which, as Sarah mentioned, can be cut to the appropriate length of your cavity. And we also, just to bear in mind, that Exufiber, the ribbon version, is the same material and will deliver on absorbency, retention, and that transferability that you'll get from just the plain, the foam, or not foam, flat version. Thank you.
Perfect. Thank you very much. Sarah, anything to add on that final question?
One quick thing to add there. We do a big size in Exufiber, so that's available also in a 20x30. So again, if you're, managing maybe a circumferential wound, around a leg, that size dressing would be great for that type of wound.
Perfect. Well, thank you very much, both of you, for your insights in those questions, and for a great presentation as well. Really interested. I'm sure everyone will have found that really, really valuable. So this concludes our live training session. Thank you, everybody, for watching and for sending in your questions and comments. If we didn't get through to your question, then we will try and answer those in the next couple of days. And you can always get in touch with the Mölnlycke team from those contacts on one of the slides earlier. A big thank you to Mölnlycke and the whole team there. Thank you for your support. We really do appreciate it. And like I said, make sure you contact the Mölnlycke team. You can click on the 14-day challenge link. You can request your clinical samples there, and Maeve, Sarah, and the rest of the clinical support managers at Mölnlycke will be able to help with any questions you've got on education or support that you might need. So the certificate link should now be on your screen. You can click on that, download your certificate to go into your CPD portfolio. Remember to like the JCM page. We've got lots more Facebook Lives and virtual lunch meetings coming up. Our next virtual lunch meeting is on the 12th of April and titled Negative Pressure Wound Therapy, Simplified with PICO. So that's all from us. Thank you very much for joining us, and we'll see you next time.